So before I get started, I just want to start off with the caveat that I am here representing ASEM as a stand-in. Many of our leadership are actually, this meeting actually runs concurrently with the American Association of Treatment of Opiate Dependence annual meeting. So many of our leadership is actually attending that meeting. So I do not have prepared slides, but I will kind of speak. I'm actually wrapping up my first year as a member of the board of ASEM. I represent Region 5. There are 10 regions in ASEM. I represent Region 5, which includes Maryland, Virginia, North Carolina, South Carolina, West Virginia, Delaware, and Georgia, and the District of Columbia. Just to give you a little bit of background about the American Society of Addiction Medicine, hereafter referred to as ASAM. ASAM was founded in 1954. It's the nation's oldest and largest medical specialty organization. Right now, we represent more than 5,500 physicians and other clinicians who specialize in the treatment of addiction medicine. So while we are primarily a physician-led organization, we actually have, within the last 3 years, included associate memberships. That includes licensed professionals who are also working in the area of addiction. And so we realize that inclusive, but not limited to, licensed clinical psychologists, LCAD, so licensed clinical alcohol drug counselors, social workers, nurses, pharmacists, et cetera. So because we realize that that this takes a multidisciplinary team-based approach, and that this is not something that physicians are going to be doing alone. In terms of some of the focus areas for ASAM, one of the largest focus areas, and continues to be a focus area, is increasing access to treatment. So we know that prior to the ACA, approximately 34% of enrollees in individual market plans did not have coverage that included addiction treatment services. We know that Medicaid accounts for about 1/5 of all substance use disorder treatment and about 1/4 of medication spending on specifically medications for treatment of opiate addiction. And so medication expansion has also been associated with an 18.3% reduction in unmet need for SUD treatment. And so with the recent and anticipated continued efforts at kind of repealing the Affordable Care Act and reducing Medicaid expansion, ASAM is continuing to advocate for continued expansion of treatment and maintenance of coverage, that the coverage gains that we're seeing with the expansion of the ASAM, with the expansion of Medicaid benefits. We also want to make sure that any whatever subsequent models are proposed that would not allow states to waive the essential health benefits, because again, that's how we were able to get addiction and mental health treatment covered. And so we're not in favor of any efforts to go to block gap funding or block grant funding, I should say, of Medicaid. We also know that there's an overwhelming evidence that supports the use of FDA-approved medications. However, there continue to be limitations on access to those medications, including use of prior authorizations, fail first policies, and so ASAM does not support any of those policies. We actually support removing prior authorizations and removing those fail first policies, anything that's going to limit people in terms of their ability to access what we know are evidence-based medications for the treatment of opiate use disorders. We also know that the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008 was passed, but there still continue to be gaps in terms of enforcement of that Parity Act. And so ASAM, again, is supporting particularly local efforts in terms of enforcement of the Parity Act, and to making sure that, again, that patients have equal access to addiction and mental health treatment along with physical health treatment. We released national practice guidelines for the use of medications in the treatment of addictions involving opiate use. One of the other areas that ASAM is targeting is particularly workforce expansion. So I believe at one of the discussion yesterday, there was a mention of how we need to look at actually including expanding the workforce, inclusive of nurse practitioners, physician assistants. So ASAM has been a leader in that area, and we know that there are too few healthcare providers to respond to this treatment. And so ASAM has been a advocate of Representative Paul Tonko's bill, the Addiction Treatment Access and Improvement Act, which still in committee. But this bill would actually codify in statute that addiction specialist physicians may prescribe buprenorphine up to the 275 patient limit. It would eliminate the sunset date. So right now we have expansion of coverage because we've allowed nurse practitioners and physician assistants to prescribe buprenorphine, but there's a sunset date to that. So we want to eliminate that sunset date for that prescribing authority. And then we also want to, as was actually mentioned yesterday, this bill would also expand prescribing authority to nurse anesthetists, clinical nurse specialists, and nurse midwives. And so ASAM is a supporter of this bill. We are supporters, ASAM is in support of, again, expanding the workforce, so including increasing the number of addiction medicine fellowships across the country. Last year was actually the addiction medicine has actually been recognized as a medical specialty now, and last year was the first year for the exam that was administered by the American Board of Preventive Medicine, and so ASAM was a leader in that effort. However, we want to continue that effort, as I said, including expansion of addiction medicine fellowships. However, we also are interested in developing a pathway for physicians who do not have a primary board. And so that's one of the efforts that ASAM is going to continue to be involved in. ASAM recently underwent a strategic planning process. And as part of that planning process, we realized, as we had this focus on workforce development and education of the workforce, but the strategic planning process now also includes, we really want to make sure that we are including the voice of the patient and the family in our programming and our advocacy efforts. We realize that addiction is a family disease, and so we need to get the voice of the family, and that we think will also, and the patient, and that we think will go a long way in terms of reducing stigma that's still related to not only the disease of addiction, but the treatments associated with it. And then one of the last things in terms of funding initiatives, we know that there's an urgent need for increased funding for both the National Institute on Drug Abuse and the National Institute of Alcohol Abuse and Alcoholism, so NIDA and NIAAA. And we know that their research is critical to better understanding addiction, particularly the intersection between pain and addiction, so ASAM supports that. And one of the things that ASAM has done, we know that a lot of things occur on the local level. So one of the things that ASAM did, and as I'm also the president of the Maryland, D.C. chapter, and what I can tell you is they have added a liaison in their national office that actually works with the state chapters on different policy issues. So if there's different policy issues that arise on the local level, their liaison will help us in terms of writing testimony or providing policy information or kind of ASAM stance on that. That has been a huge benefit to the local chapter. So ASAM is working not only at the federal level, but at the state and local level as well. ASAM has its particular products that it's developed. So we know that the ASAM criteria are research-validated set of guidelines that provide outcome-oriented and result-based care and treatment of addiction. And then ASAM has also developed Continuum, which is a web-based decision support system that guides healthcare providers through a structured interview and will help in terms of placement based upon the ASAM criteria. So I had a little bit more, but I think I'll stop there.